السلام عليكم ورحمة الله. احنا يا جماعة النهاردة هنتكلم عن الكوروناري ارتري ديسيز كيس سيناريوز. هنتكلم عن 2 كيسز وهنشوف كده البرزنتيشن بتاع الكيس، ايه الانفستيجيشن اللي نعملها وايه البروبر مانجمنت، بحيث ان احنا نبقى بنتكلم ابلايد مش كلام نظري. This is the first case. Mr. M.A. He is 65 years old, heavy smoker, presented to ER complaining of acute chest pain, started 2 hours before presentation to hospital. His chest pain was at rest, diffuse, radiating to both shoulders and lower jaw, and was associated with vomiting. His past history was positive for hypertension and poorly controlled diabetes, and he had positive family history of coronary artery disease. On examination, patient was conscious, but he was orthopnic and distressed. His pulse rate was 110 per minute, with regular rhythm and equal on both sides. His blood pressure was 160/100. By auscultation, heart auscultation revealed S3 gallop rhythm and bilateral basal rolls or crepitations on his chest. ECG was done immediately. As we can notice from this ECG, there is ST elevation in the anterolateral leads with reciprocal ST depression in the inferior leads. So this is ECG of a case with acute anterolateral ST elevation myocardial infarction, acute anterolateral STEMI, MI. As the patient was orthopnic and has S3 gallop rhythm and bilateral basal rolls, so his MI was complicated with acute heart failure. So rapidly we started loading by antiplatelet, anticoagulant, and statin therapy: 300 mg acetyl salicylic acid, aspirin, 300 mg clopidogrel, and 1 mg per kg low molecular weight heparin, and 80 mg atorvastatin. Besides, nitroglycerin patch was applied, IV morphia was given as painkiller, and 40 mg furosemide diuretic was given for the heart failure and congestion, and the patient was transferred quickly to the CCU, coronary care unit or cardiac care unit. In the CCU, we performed rapid echocardiography screening, which showed severe anterior left ventricular wall hypokinesia, which is supplied by the left coronary artery, which is occluded according to the ECG. Reduced left ventricular systolic function, ejection fraction was about 38%, with mild to moderate mitral regurg and no mechanical complications related to MI. His initial cardiac biomarkers were still negative because he was early presenter, only 2 hours post chest pain, but follow-up cardiac biomarkers were positive. As patient was presenting early within 3 hours of the chest pain, and primary BCI team was not activated, so we started to infuse fibrinolysis or thrombolytic therapy. 1.5 million units of streptokinase was infused over 30 minutes. After finishing streptokinase, patient still had chest pain, still in heart failure, and without much resolution or improvement of the ST elevation in his ECG, so we consider this as a failed thrombolytic therapy or failed fibrinolysis, and we have to search for another solution. We give another dose of morphia, and while discussing, the patient became suddenly agitated and unconscious with the following rhythm on the EKG monitor. As we can appreciate from this ECG, it showed wide QRS tachycardia. This is the classic pattern of ventricular tachycardia. This is a fatal rhythm. So we have to appreciate this ECG and know its morphology, its shape, and go immediately to defibrillate or to cardiovert using DC shock. Immediate DC shock was given with resuscitation of his spontaneous circulation. Patient regained consciousness and sinus rhythm. and primary or rescue BCI team was activated. Patient was reloaded by 190 mg antiplatelet ticagrelor and pushed rapidly to the cath lab. Cardiac catheterization revealed that his left anterior descending coronary artery had proximal to mid total occlusion, which was opened by wiring and stenting. As we can appreciate here, this is a total occlusion of the main left coronary artery, left anterior descending, which supply about 70% of the myocardium, and the second photo after wiring, ballooning, and stenting of the lesion with regaining of his LED and regaining of the supply to the myocardium. Patient greatly improved and discharged on the second day. We advised him to adopt a healthy lifestyle, exercise, rehabilitation, and close follow-up for his hypertension and diabetes. He was kept on dual antiplatelet therapy and lifelong aspirin, beta blocker, ACE, and statin. Regarding the second case, Mr. RG, he was 50 years old male, heavy smoker. He presented to the outpatient clinic, not to the ER, complaining of recurrent attacks of epigastric pain. In between the attacks, the patient is completely normal. The attacks are short-lasting, associated with sweating, precipitated by heavy meals and exhaustion, and relieved by rest. His GIT doctor prescribed antacids and proton pump inhibitors, but not completely relieved the pain. With time, the attacks became more frequent and more severe. His past history was positive for diabetes. He did upper GIT endoscopy, which was normal. He has no relevant family history. On physical examination, patient was conscious, lying flat. His pulse rate was 75 per minute with regular rhythm and equal on both sides. Blood pressure was 120/75. His heart and chest auscultation showed no abnormal findings. His ECG was normal and cardiac enzymes were negative. The cardiologist prescribed for him on-demand sublingual nitrates as therapeutic test, which was sufficient to terminate the attacks. Also, he requested for stress ECG, which was positive and revealed horizontal ST depression, which is a positive finding for ischemia. Compared to the previously normal ECG, when the patient run on his treadmill, as we can see, there is diffuse ST depression in the ECG with ST elevation in the EVR, which is a strongly positive stress test for mostly multivessel coronary artery disease. Thus, diagnosis of unstable angina was confirmed. Patient was scheduled for coronary angiography, which showed significant multivessel coronary artery stenosis, which were successfully stented. He was kept also on dual antiplatelet therapy and then on lifelong aspirin, beta blocker, ACE, and statins. As we can see from this photo, this is a coronary angiography showing distal significant right coronary artery stenosis, which was stented. Also, this is mid or proximal to mid subtotal left coronary artery occlusion, which was successfully stented. Also, this was mid significant or subtotal left circumflex stenosis, which was successfully stented. Our home message: first, when you are resident in the ER, you should be able to rule out the 4 fatal causes of acute chest pain: myocardial infarction, aortic dissection, pulmonary embolism, and tension pneumothorax. Any other cause of chest pain will not or would not be fatal. So we have to mention and remember these 4 fatal causes of acute chest pain. If you cannot diagnose correctly, you can or you mostly will lose this patient. Also, we have to identify the risk factors of coronary artery disease like smoking, hypertension, diabetes, age. Identify the characters of typical chest pain, which is exertional, relief virus or sublingual nitrate, diffuse. Time is myocardium, so we should obtain an ECG quickly for the patient with acute chest pain. We have to identify the role of echocardiography in acute coronary syndrome to exclude other differential diagnoses like pulmonary embolism dissection, aortic dissection, and to exclude mechanical complications of MI like ventricular rupture, ventricular pseudoaneurysm or true aneurysm, pericardial effusion, acute mitral regurg, papillary muscle rupture, or VSD due to septal rupture, interventricular septal rupture. Also, we have to be aware for the first line of management in acute coronary syndrome to give the anticoagulant, antiplatelets, statins, and nitrate and painkiller. We have to be aware for the fatal heart rhythms like VT and VF and learn how to defibrillate using the DC shock. In case of failed fibrinolysis, we should do BCI for the patient immediately, percutaneous coronary intervention. Be aware of the atypical presentations of acute coronary syndrome like epigastric pain, especially when it is recurrent, prolonged, and non-responding to the medications. Please remember this advice. Any acute prolonged pain from the umbilicus to jaw should be investigated for coronary artery disease by ECG or non-invasive stress test. Even with normal ECG, as the second patient could have multi-vessel coronary artery disease, so you can request for non-invasive diagnostic tool like stress ECG. Generally speaking, in selected patients with chronic coronary syndrome, long-term medical treatment without intervention can be enough. But in patients presenting with acute coronary syndrome, invasive strategy using cardiac cath plus PCI or CABG has better acute and long-term outcomes than medical treatment. Thank you.